ಕಾಣ್ತಾ ಇಲ್ಲ.
ಇಲ್ಲ, ನಾನು ಆಡಿಯೋದಲ್ಲಿ ಹಾಕೊಂಡಿದ್ದೇನೆ, ಯಾಕಂದ್ರೆ ನನ್ ಬೇರೆ ಕೆಲಸ ಇತ್ತು ಕಿಸೆಲ್.
ಗುಡ್ ಈವ್ನಿಂಗ್ ಸರ್, ಮಂಜುನಾಥ್ ಸರ್. ಗುಡ್ ಈವ್ನಿಂಗ್ ಸರ್. ಗುಡ್ ಈವ್ನಿಂಗ್. ಇದು ಕೇಳಿಸ್ತಿಲ್ಲ ಆಡಿಯೋ?
ಕೇಳಿಸ್ತಾ ಇದೆ.
ಇಲ್ಲ, ಅವ್ರದ್ದು ಡಾಕ್ಟರ್ ಮಂಜುನಾಥ್ ಅವ್ರದ್ದು ಕೇಳಿಸ್ತಾ ಇದೆ. ನಮಸ್ಕಾರ ಸರ್.
ನಾನು ಇನ್ನು ಯಾರೋ ಬಂದಿರಲ್ಲ, ನಾನೇ ಫಸ್ಟ್ ಏನು ಅನ್ಕೊಂಡು
ಇಲ್ಲ ಇನ್ನೊಂದು 5 ನಿಮಿಷಗೆಲ್ಲ ಜಾಯ್ನ್ ಆಗ್ತಾರೆ. ಇವತ್ತೆಲ್ಲ ಸುಮಾರು ಕಡೆ ಕಳಿಸಿದ್ದೀವಿ.
ವೀರಣ್ಣ ಸರ್ ನಮಸ್ಕಾರ. ವೀರಣ್ಣ ಸರ್
ನಮಸ್ತೆ ಸರ್.
ಇಲ್ಲ ಇನ್ನೊಂದು 5 ನಿಮಿಷಗೆಲ್ಲ ಜಾಯ್ನ್ ಆಗ್ತಾರೆ. ಇವತ್ತೆಲ್ಲ ಸುಮಾರು ಕಡೆ ಕಳಿಸಿದ್ದೀವಿ.
ವೀರಣ್ಣ ಸರ್ ನಮಸ್ಕಾರ. ವೀರಣ್ಣ ಸರ್
ಸರ್. ಪ್ರಸಾದ್ ಸರ್ ನಮಸ್ತೆ. ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ.
ನಮಸ್ಕಾರ ಸರ್.
ನಮಸ್ತೆ. ನಮಸ್ತೆ ದೀಪಕ್ ಸರ್. ಚಲಪತಿ
ನಮಸ್ಕಾರ ಸರ್.
Good evening everybody. Good evening everybody.
Good evening Dr. Deepak sir.
Good evening Dr. Deepak. Good evening.
Venkata Chalpati sir, can you hear me?
Yeah, sure. Yeah, definitely.
Yeah. It is live on YouTube now.
Yeah.
ಸರ್ ಯೂಟ್ಯೂಬ್ ಅಲ್ಲೂ ಗೊತ್ತಾಗುತ್ತೆ ಎಷ್ಟು ಜನ ಇದ್ದಾರೆ ಲಾಗಿನ್ ಆಗಿದ್ದಾರೆ.
ಇಲ್ಲ ಆಗಿದ್ದಾರೆ. ಪ್ರಸಾದ್ ಸರ್.
ಸರ್ ಹೇಳಿ ಸರ್.
ಯು ಟೇಕ್ ದ ಲೀಡ್ ಇನ್ ದ ಸೆನ್ಸ್.
ಸರ್
ನಮ್ಮ ಇದು ಯಾವುದು ಇದು ರೆಡಿ ಇದೆಯಾ? ಫ್ಲಾಗ್ ಸಾಲ್ಯೂಟೇಷನ್.
ಒಂದು ನಿಮಿಷ ನೋಡ್ತೀನಿ, ಒಂದು ಸೆಕೆಂಡ್. ಸರ್ ರೆಡಿ ಇದೆ, ಸ್ಟಾರ್ಟ್ ಮಾಡಲಾ? ಇನ್ನೊಂದು ಸ್ವಲ್ಪ
ಬೇಡ, ಇನ್ನೊಂದು 5 minutes. 8:26 8:30 ಎಕ್ಸಾಕ್ಟ್ಲಿ ವಿಲ್ ಸ್ಟಾರ್ಟ್. ಮಂಜುನಾಥ್ ಸರ್ ರೆಡಿ ಇದಾರೆ ನೋಡಿ.
ಸರ್ ನಾನು ರೆಡಿ ಇದ್ದೀನಿ ಸರ್.
I think he was there. He was there.
ಒಂದು ನಿಮ್ಮ ಅನ್ಸಿದ ಬ್ಯಾಕ್ ಗ್ರೌಂಡ್ ಅಲ್ಲಿ ಒಬ್ರು ಬಂದಿದ್ರು ಸರ್. ಯಾರು?
ಡಾಕ್ಟರ್ ಸುರೇಶ್ ಇರ್ಬೇಕು ಸರ್.
ಮತ್ತೆ
ನಮಸ್ತೆ ವಂದನಾ.
ನಮಸ್ತೆ ಸರ್. ನಮಸ್ತೆ ಕರುಣ. ನಮಸ್ತೆ.
ನಮಸ್ಕಾರಪ್ಪ.
ನಮಸ್ತೆ ಸರ್.
ನಮಸ್ಕಾರ ಶ್ರೀನಿವಾಸ್.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ ಗುರುಗಳೇ. ಬಿಜ್ಜಲ್ ಗುರುಗಳೇ ನಮಸ್ಕಾರ. ನಮಸ್ಕಾರ.
ಹಾಯ್ ಪ್ರಸಾದ್. ಗುಡ್ ಈವ್ನಿಂಗ್.
ನಮಸ್ಕಾರ ಡಾಕ್ಟರ್ ವೆಂಕಟಾಚಲಪತಿ. ನಮಸ್ಕಾರ. ಸ್ಟ್ಯಾಂಡ್ ಹಾಕ್ಬಿಟ್ಟಿದೀನಿ, ಮೊಬೈಲ್ ಬಂದು.
ಒಳ್ಳೆ ಕೆಲಸ.
ಸ್ಟ್ಯಾಂಡ್ ಸಿಕ್ತು ಮೊನ್ನೆ, ಹಾಕ್ಬಿಟ್ಟಿದೀನಿ. ಸ್ಟ್ಯಾಂಡ್ ಕರೆಕ್ಟ್ ಆಗಿರ್ತದೆ ಹೆಂಗೆ ಅಂತ.
ವೆರಿ ಗುಡ್.
ಟೇಬಲ್ ಮೇಲೆ ನಿಂತ್ಕೊಳ್ಳುತ್ತದು.
ವೆರಿ ಗುಡ್.
ಪ್ರಸಾದ್ ಸರ್.
ಸರ್ ಹೇಳಿ ಸರ್.
You have to make a video. I mean studio.
ಸರ್ ನನಗೆ ಸ್ಕ್ರೀನ್ ಶೇರಿಂಗ್ ಆಪ್ಷನ್ ಕೊಡಿ ಸರ್.
Yeah, I'll make you. ಈಗ ಕೊಡ್ತೇನೆ ನೋಡಿ. Yeah. Yes sir.
ಆಗಿದೆ ಸರ್. ಥ್ಯಾಂಕ್ ಯು.
ಆಗಿದೆ. ಓಕೆ.
ಹೌದಾ? ನೋಡ್ತಾ ಇದ್ದೀರಾ?
ಅದೇ ಸ್ಟುಡಿಯೋ ಮಾಡ್ಕೋಬೇಕು ಸರ್. ಮಧುಸೂದನ್ ಸರ್ ಒಂದು
ವರ್ಚುವಲ್ ಬ್ಯಾಕ್ ಗ್ರೌಂಡ್ ಒಂದು ಮಾಡಬೇಕು ಪ್ರಸಾದ್ ಅವರೇ.
ಅದೇ ಸರ್, ಅದೇ ಮಾಡ್ಕೋಬೇಕು ಅಂತ.
ಒಂದ್ಸಾರಿ ಮಾಡೋಣ.
ನಮ್ ಶ್ರೀನಿವಾಸ್ ಡಾಕ್ಟರ್ ಕರೆಕ್ಟ್ ಆಗೈತೆ, ನಿಮ್ಗೆ ಗೊತ್ತಾಗಲ್ಲ ವೈಟ್ ಕಲರ್ ಇದೆ ಬ್ಯಾಕ್ ಸೈಡ್.
ತಲೆ ಮೇಲೆ ಸ್ವಿಚ್ ಇಟ್ಕೊಂಡವ್ರೆ ಸೀನಣ್ಣ.
ಮಾಡಬಿಟ್ಟ
ಸ್ವಿಚ್ ತಲೆ ಮೇಲೆ ಇದೆ ಸೀನಣ್ಣಗೆ.
ದೀಪಕ್ ನಮಸ್ಕಾರ
ಸರ್. ನಮಸ್ತೆ.
ನಮಸ್ತೆ ಸರ್. ನಮಸ್ತೆ.
ನಮಸ್ತೆ ಡಾಕ್ಟರ್ ಮಂಜುನಾಥ್ ಸರ್. ಗುಡ್ ಈವ್ನಿಂಗ್.
ನಮಸ್ತೆ.
ಏನಪ್ಪ ಚಳಿ ಆಗ್ತಿದೇನಪ್ಪ?
ಹೌದಪ್ಪ, ತುಂಬಾ ಚಳಿ ಇದೆ ಬೆಂಗಳೂರಲ್ಲಿ.
ಚಿಕ್ಕಬಳ್ಳಾಪುರದಲ್ಲಿ
ಮನೇಲಿ ಎಲ್ಲ ಕಿಟಕಿ ಬಾಗಿಲೆಲ್ಲ ಬಂದ್ ಮಾಡ್ಕೊಂಡ್ರು ಸ್ವಲ್ಪ ಚಳಿ ಇದೆ.
ಫುಲ್ ಮಳೆ ಇಲ್ಲಿ.
ಇಲ್ಲೂ ಮಳೆ ಇದೆ, ಚಳಿನೂ ಜಾಸ್ತಿ ಇದೆ ಮಳೆಗಿಂತ. ಇಲ್ಲೂ ಮಳೆ ಇದೆ, ಚಳಿನೂ ಜಾಸ್ತಿ ಇದೆ ಮಳೆಗಿಂತ.
ಯೂಟ್ಯೂಬ್ ಅಲ್ಲಿ ರಿಪ್ಲೈ ಇದಾಗ್ತಿದೆ ಅನ್ಸುತ್ತೆ, ಯಾಕೋ ಆಗ್ತಿದೆ ಅನ್ಸುತ್ತೆ. ಯೂಟ್ಯೂಬ್ ಅಲ್ಲಿ ಸ್ವಲ್ಪ ನಿಧಾನ ಆಗುತ್ತೆ ಲೈವ್ ಸ್ಟ್ರೀಮ್ ಗಿಂತ.
3 minutes ಬಫರ್ ಟೈಮ್ ಆಗುತ್ತೆ ಸರ್.
3 minutes ಅದಕ್ಕೆ ನಿಧಾನಕ್ಕೆ ಬರುತ್ತೆ.
ಪ್ರಸಾದ್ ಏನೇನೋ ಕಾಣಿಸ್ತಾ ಇದೆ ಹಿಂದೆ.
ನನ್ನ ಹತ್ರ ನಾನು ಇನ್ನ ಇದ್ರಲ್ಲಿ ಇದೀನಿ, ಹೊಡ್ತಾ ಇದೀನಿ. ನೀನು ಯಾರೋ ಮಳೆ ಅನ್ಬಿಟ್ಟು ಕಾಯ್ಕೊಂಡು ಕೂತ್ಕೊಂಡ ಇಲ್ಲ
ಹಿಂದೆ.
ತಿರುಗಿಸ್ಬಿಡ್ಲಾ ಹಿಂಗೆ?
ಅದಕ್ಕೆ
ಇಲ್ಲ, ಸ್ಯಾನ್ ಫ್ರಾನ್ಸಿಸ್ಕೋ ಬ್ರಿಡ್ಜ್ ಹಾಕ್ಬಿಡ್ತೀನಿ ಸಿಕ್ಕಿದ್ರೆ. ಹಿಂದ್ಗಡೆ ಸ್ಯಾನ್ ಫ್ರಾನ್ಸಿಸ್ಕೋ ಬ್ರಿಡ್ಜ್ ರೆಡಿ ಇದೆ ಅನ್ಸುತ್ತೆ. ಮತ್ತೆ ಎಲ್ಲಾರ ನನ್ಗೆ ಮತ್ತೆ ಯಾಕೆ ಅಂತ
ಬದ್ಸುದನ್ನ ಚೆನ್ನಾಗಿ ಹಾಕೊಂಡಿದ್ದಾರೆ ನೋಡ್ರಿ.
ಏನ್ ಬೇಕಾದ್ರೆ ಆಟ ಆಡ್ಬೋದು ಸರ್ ಇದ್ರಾಗ.
ಚೆನ್ನಾಗಿದೆ ಅದು.
ಬದ್ಸುದನ್ನ ತುಂಬಾ ಚಾರ್ಮಿಂಗ್ ಆಗಿ ಕಾಣಿಸ್ತಿದ್ರು.
ಭಾರ ಕಮ್ಮಿ ಆಯ್ತಲ್ಲ ಸರ್, ಅದಕ್ಕೆ
ತಲೆನೋವು ಕಡಿಮೆ ಆಗ್ಬಿಟ್ಟಿದೆ ಸರ್.
ಅದಕ್ಕೆ ಫುಲ್ ಇದು ನೋ ಟೆನ್ಷನ್.
ಚೇಂಜ್ ಆಗ್ತಿದೆ ಅಲ್ಲ ಬ್ಯಾಕ್ ಗ್ರೌಂಡ್.
ಈಗ ವುಡನ್ ಬ್ಯಾಕ್ ಗ್ರೌಂಡ್ ಬಂತು ಸರ್. ಇದಂಗ್ ಮಾಡಿದ್ರಿ ವುಡನ್ ಬ್ಯಾಕ್ ಗ್ರೌಂಡ್ ಹೆಂಗ್ ಮಾಡಿದ್ರಿ?
ಏನೋ ಮಾಡೋದು
ವರ್ಚುವಲ್ ಬ್ಯಾಕ್ ಗ್ರೌಂಡ್ ಚೇಂಜ್ ಮಾಡ್ಬೋದು ಸರ್.
ಫೋಟೋಶಾಪ್ ಮಾಡ್ಕೊಂಡು ಒಳ್ಳೆ ರೆಸಲ್ಯೂಷನ್ ಅಲ್ಲಿ ಬ್ಯಾಕ್ ಡ್ರಾಪ್ ಅಲ್ಲಿ ಇದನ್ನ ನಾವು ಫೋಟೋಶಾಪ್ ಅಲ್ಲಿ ಮಾಡ್ಕೊಂಡು ಸ್ಟೋರ್ ಮಾಡಿ ಇಟ್ಕೋಬೇಕು. then we can change it.
ಬಟ್ ಒಂದೊಂದ್ಸರಿ ನಾವ್ ಇಮೇಜ್ ಏನೇನೋ ಒಂಥರ ಶೇಕಿ ಆಗ್ತಿರುತ್ತಲ್ಲ.
ಇಲ್ಲ, that's what see I'll show you. ಒಂದು ಬಿಳಿ ಬಟ್ಟೆ, ಇದು ಗ್ರೀನ್ ಬಟ್ಟೆ ಇರುತ್ತಲ್ಲ, ಅದನ್ನ ಹೊಲ್ಸ್ಕೋಬೇಕು ನೀವು. ಹೊಲ್ಸ್ಕೊಂಡು ನನ್ನ ಬ್ಯಾಕ್ ಗ್ರೌಂಡ್ ಅಲ್ಲಿ ಗ್ರೀನ್ ಬಟ್ಟೆ ಹಾಕೊಂಡಿನಿ ಸ್ಕ್ರೀನ್.
ಹೌದಾ?
ಹೌದು, ಗ್ರೀನ್ ಬ್ಯಾಕ್ ಗ್ರೌಂಡ್ ಇರಬೇಕು.
ಅಂದ್ರೆ ಒಂದೇ ಕಡೆ ಸ್ಟ್ಯಾಟಿಕ್ ಇರ್ಬೇಕು ಹಂಗಾದ್ರೆ.
ಹೌದು, ಒಂದೇ ಕಡೆ ಸ್ಟ್ಯಾಟಿಕ್. ಯು ಕ್ಯಾನಾಟ್ ಮೂವ್.
ಸ್ಟ್ಯಾಟಿಕ್
ಮೂವ್ ಮಾಡಂಗಿಲ್ಲ.
ವರ್ಚುವಲ್ ಬ್ಯಾಕ್ ಗ್ರೌಂಡ್ ಚೇಂಜ್ ಆಗಲ್ಲ ಸರ್.
ಹೌದು.
ಓಹೋ.
ಸೊ ಗ್ರೀನ್ ಇರಬೇಕು, ಲೈಟ್ ಗ್ರೀನ್, ಸ್ವಲ್ಪ ಡಾರ್ಕ್ ಗ್ರೀನ್ ಬ್ಯಾಕ್ ಗ್ರೌಂಡ್ ಹಾಕೊಂಡ್ರೆ ಯು ವಿಲ್ ಗೆಟ್ ಬ್ಯೂಟಿಫುಲ್ ಬ್ಯಾಕ್ ಗ್ರೌಂಡ್ಸ್. ಇದನ್ನ ವರ್ಚುವಲ್ ಬ್ಯಾಕ್ ಗ್ರೌಂಡ್ ಮಾಡ್ಕೋಬಹುದು ನಾವು.
ಸರ್ ನಂದು ವರ್ಚುವಲ್ ಬ್ಯಾಕ್ ಗ್ರೌಂಡ್ ಅದು ನಾನ್ ಕುತ್ಕೊಂಡಿರೋದು.
ನೀವೇನ್ ಹಾಕೊಂಡಿದ್ರಿ ಹಿಂದೆ?
ಅದ್ ನಮ್ ನರ್ಸಿಂಗ್ ಹೋಮ್ ಲೋಗೋ ಸರ್ ಅದು.
ಬಟ್ ಏನಾಗುತ್ತೆ, ಕೆಲವು ಲೈಟ್ ಕಲರ್ ಬ್ಯಾಕ್ ಗ್ರೌಂಡ್ ಗೋಡೆ ಇದ್ರೆ ಚೆನ್ನಾಗಿ ಬರುತ್ತೆ. ಒಂದೇ ಕಲರ್ ಇರ್ಬೇಕು. ಸರ್ ಮಾಡ್ಕೊಂಡಿದ್ದಾರೆ ನೋಡಿ.
ಸರ್ ಅದ್ರೊಳಗೆಲ್ಲ ಫಂಡ್ಸ್.
ವಿಡಿಯೋ ಇಂದ ಆಚೆ ಹೋದ್ರೆ ಏನೋ ಇಟ್ಟೋಗ್ತಿದ್ರಲ್ಲ, ಅದೇನ ನಮ್ಗೆ ಗೊತ್ತಾಗಿಲ್ಲ. ಅದು
ಯಾವ ಸರ್?
ಅದೇ ನಮ್ ಪ್ರೆಸಿಡೆಂಟ್ ಸೆಕ್ರೆಟರಿ ಮೀಟಿಂಗ್ ಅಲ್ಲಿ ನೀವೇನೋ ವಿಡಿಯೋ ಆಫ್ ಮಾಡಿದ್ರೆ ಸಮಥಿಂಗ್ ಯು ಆರ್ ಪುಟಿಂಗ್, ನಿಮ್ ಬರೀ ಏನೋ ಇದು ಬರ್ತಿತ್ತು ಯಾವಾಗ್ಲೂ.
ನಮ್ದು ಇದು ಅದು ಈಗ ಬರುತ್ತೆ ನೋಡಿ.
ಇದು ಹೆಂಗ್ ಹಾಕೋದು ಅಂತ ಗೊತ್ತಾಗಿಲ್ಲ. ನಾನು ಎಲ್ರು ಕೇಳಿದ್ರು ಗೊತ್ತಾಗಿಲ್ಲ. ನಿಮ್ಮನ್ನೇ ಕೇಳೋಣ ಅಂತಿದ್ದೀನಿ. ಆಮೇಲೆ ಕೇಳ್ತೀನಿ.
ಆಮೇಲೆ ಹೇಳ್ತೀನಿ ನೋಡಿ.
ಆಮೇಲೆ ಹೇಳ್ತೀನಿ.
ಬೆಂಕಿ ಹಚ್ಚೋದಾಗ
ಅದಿಟ್ಬಿಟ್ಟು ಹಾಕ್ಬಿಟ್ಟು ಹೋಗ್ತಿದ್ರಿ. ನನಗ್ ಗೊತ್ತಾಗ್ತಿರ್ಲಿಲ್ಲ. ನಾನ್ ನಿದ್ದೆ ಮಾಡಿದ್ರು ಎಬ್ಬಿರ್ತಿದ್ರಲ್ಲ ಅವಾಗ.
ನೀವು ನಿದ್ದೆ ಮಾಡ್ತಾ ಇದ್ರಿ, ಗೊತ್ತಾಗ್ತಿಲ್ಲ. ಮಜಾ ಇತ್ತು ಅದು. ಇಟ್ ವಾಸ್ ರಿಯಲಿ.
ಹೌದು.
Yes sir. Can we start? It is 8:33. ಪ್ರಸಾದ್ ಸರ್
ಮಾಡ್ಬೋದಾ ಸರ್?
ಪ್ಲೀಸ್ ಸ್ಟಾರ್ಟ್ ಸರ್. ಬಿಜಾ,
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ
ಸರ್. ಪ್ರಸಾದ್ ಸರ್, ಒಂದ್ ನಿಮಿಷ. ಬಿಜಾ ಸ್ಟೇಟ್ ಸೆಕ್ರೆಟರಿ ಇದ್ದಾರೆ. He will read the IMA prayer and flag salutation. Then you take over.
ನಮಸ್ಕಾರ ಸರ್.
ನಮಸ್ತೆ ಶಿವಕುಮಾರ್ ಸರ್. I'll mute everyone. I'll mute everyone except 2-3 people. Okay? Don't feel otherwise. ಚಲಪತಿ ಅನ್ಮ್ಯೂಟ್ ಮಾಡ್ಕೊಳ್ಳಿ.
ಮಾಡಿದೀನಿ.
ಹರೀಶ್ ಬಡ ಮಾಡಿ ಸರ್, ಅನ್ಮ್ಯೂಟ್ ಮಾಡ್ಕೊಳ್ಳಿ. ಅನ್ಮ್ಯೂಟ್. ಪ್ರಸಾದ್ ಅನ್ಮ್ಯೂಟ್ ಯುವರ್ ಸರ್.
ಪ್ರಸಾದ್.
ಕಾರನ್ ಸರ್ ಅನ್ಮ್ಯೂಟ್ ಮಾಡ್ಕೊಳ್ಳಿ. Unmute. Prasad, unmute.
sir.
Yeah.
Yeah,
Karan sir, unmute ಮಾಡ್ಕೊಳ್ಳಿ.
Yeah.
Harish?
Harish is there?
Yeah, he is there.
Yeah. Oh.
Harish, unmute yourself. Bijal, unmute yourself. Yeah.
Yeah, done.
Yeah. Okay, fine. Prasad sir, please.
Good evening, everybody. We welcome you to this very interesting session, which is jointly organized by ima-ksb, NIMHANS, and IFPS KC. So the topic for today is psychiatry for IMA members of Karnataka. So I want to read the prayer. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪ್ರಾರ್ಥನೆ. ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಅಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಿರಲಿ. Flag salutation. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it and realizing our responsibilities as the accredited members of this national organization. We swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind, long live IMA. Thank you.
Dr. Somsekhar Bijal, Secretary of IPS KC, I request him to take over.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಈ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ರಾಜ್ಯ ಶಾಖೆ, ಭಾರತೀಯ ಮನೋವೈದ್ಯಕೀಯ ಸಂಘ ಕರ್ನಾಟಕ ಶಾಖೆ ಹಾಗೂ ನಿಮ್ಯಾನ್ಸ್ನ ಈ ಸಹಯೋಗದಲ್ಲಿ ಈ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ವೈದ್ಯರಿಗಾಗಿ ಮನೋವೈದ್ಯಕೀಯ ವಿಷಯವನ್ನು ಪ್ರಚಾರಪಡಿಸಬೇಕಂತ ಈ ಒಂದು ವೆಬಿನಾರ್ ಸೀರೀಸ್ಗೆ ಮತ್ತೊಮ್ಮೆ ತಮ್ಮೆಲ್ಲರನ್ನು ನಾನು ಸ್ವಾಗತ ಮಾಡ್ತಾ ಇದ್ದೀನಿ. ಮುಖ್ಯ ರೂವಾರಿಗಳು ಮಧುಸೂದನ್ ಅವರು ಇದ್ದಾರೆ, ಹಾಗೆ ಟೆಲಿಮೆಡಿಸಿನ್ ವಿಭಾಗದ ಹೆಡ್ ಆಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಸುರೇಶ್ ಬಡಮಠ್ ಅವರಿದ್ದಾರೆ, ಮತ್ತು ಈಗಿನ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಅಧ್ಯಕ್ಷರಾಗಿರ್ತಕ್ಕಂಥ ಚಲಪತಿ ಸರ್ ಅವರು, ಸೆಕ್ರೆಟರಿ ಸರ್ ಅವರು, ಹಾಗೂ ನಮ್ಮ IMA-KSB ಸೈಕ್ಯಾಟ್ರಿ ಸೆಲ್ಲಿನ ಕಾರಂತ್ ಅವರಿದ್ದಾರೆ, ಹಾಗೂ ಈ ದಿನದ ಒಂದು ಉಪನ್ಯಾಸಕರಾಗಿ ಆಗಮಿಸಿರ್ತಕ್ಕಂಥ ನಿಮ್ಯಾನ್ಸ್ನ ಮನೋವೈದ್ಯಕೀಯ ವಿಭಾಗದ ಸಹ ಪ್ರಾಧ್ಯಾಪಕರಾಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಮಂಜುನಾಥ್ ಅವರು, ಹಾಗೂ ಇಂದಿನ ಸಭೆಯ ಮಾಡರೇಟ್ ಮಾಡ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ದೀಪಕ್ RS, ಪಾಸ್ಟ್ IMA ಪ್ರೆಸಿಡೆಂಟ್ ಚಿತ್ರದುರ್ಗ, ಹಾಗೂ IPS KCಯ ಸಕ್ರಿಯ ಸದಸ್ಯರು, ಹಾಗೂ ಮತ್ತು ಈ ದಿನದ ಅಧ್ಯಕ್ಷತೆಯನ್ನು ವಹಿಸ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಹರೀಶ್ ದಲಂತಪಟ್ಟು, ಹಾಗೂ ಇಲ್ಲಿ ಸೇರಿರ್ತಕ್ಕಂಥ ಎಲ್ಲ ವರ್ಚುವಲ್ ಮೀಡಿಯಾದಲ್ಲಿ ಯೂಟ್ಯೂಬ್ ಇರ್ಬೋದು ಅಥವಾ ಜೂಮ್ ಅಲ್ಲಿ ಇರಬೇಕು, ಎಲ್ಲರಿಗೂ ನಾನು ಮತ್ತೊಮ್ಮೆ ಸ್ವಾಗತವನ್ನು ಕೋರ್ತಾ ಇದ್ದೀನಿ. ಈ ಒಂದು ವಿಶೇಷ ಸರಣಿಯನ್ನು ಮಾಡಿರ್ತಕ್ಕಂಥ ಉದ್ದೇಶ ಅಂತಂದ್ರೆ ಸಮುದಾಯದಲ್ಲಿರ್ತಕ್ಕಂಥ ಮನೋವೈದ್ಯಕೀಯ ಚಿಕಿತ್ಸಾ ಗ್ಯಾಪ್, ಅಂದ್ರೆ ಮೆಂಟಲ್ ಹೆಲ್ತ್ ಗ್ಯಾಪ್ ಅಂತ ಹೇಳ್ತೀವಿ, ಅದನ್ನು ಕಡಿಮೆ ಮಾಡುವ ಉದ್ದೇಶದಿಂದ ಮತ್ತು ಪ್ರಾಥಮಿಕ ಹಂತದಲ್ಲಿ ಎಲ್ಲ ವೈದ್ಯರು ಮನೋವೈದ್ಯಕೀಯ ರೋಗಗಳನ್ನು ಮನೋವೈದ್ಯಕೀಯ ಸಮಸ್ಯೆಗಳನ್ನು ಗುರುತಿಸಿಬಿಟ್ಟು ಚಿಕಿತ್ಸೆ ನೀಡಲಿಕ್ಕೆ ಅನುಕೂಲ ಆಗ್ಲಿಕ್ಕಂತ ಮಾಡ್ತಕ್ಕಂಥ ಈ ಒಂದು ಚಿಕ್ಕ ಪ್ರಯತ್ನ, ಪ್ರಥಮ ಪ್ರಯತ್ನದಲ್ಲಿ ನಾವು ಯಶಸ್ವಿ ಆಗಿದ್ದೀವಿ. ಇದನ್ನು ಹೀಗೆ ಮುಂದುವರಿಸ್ಕೊಂಡು ಹೋಗ್ತಾ ಇದ್ದೀನಿ. ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಆಗಮಿಸಿರ್ತಕ್ಕಂಥ ಎಲ್ಲ ವೀಕ್ಷಕರನ್ನು ಹಾಗೂ ಎಲ್ಲ ಸಂಘಗಳ ಪದಾಧಿಕಾರಿಗಳನ್ನು ಹಾಗೂ ನಿಮ್ಯಾನ್ಸ್ನ ಟೆಲಿಮೆಡಿಸಿನ್ ವಿಭಾಗದ ಮುಖ್ಯಸ್ಥರನ್ನು ಕೂಡ ಮತ್ತೊಮ್ಮೆ ನಾನು ಸ್ವಾಗತವನ್ನು ಮಾಡ್ತಾ ಇದ್ದೀನಿ. ಮತ್ತು ಇದೀಗ ಈ ಸಭೆಯ ಕುರಿತಂತೆ 1 ನಿಮಿಷದ ಮಾತನ್ನು ಡಾಕ್ಟರ್ ವೆಂಕಟಾಚಲಪತಿ ಅವರು IMA-KSB ಅವರು ನಡೆಸಿಕೊಡ್ಬೇಕು. ಮತ್ತು ಓವರ್ ಟು ಡಾಕ್ಟರ್ ದೀಪಕ್.
Good evening, everybody. I feel very proud to be part of this program, that is a joint venture between IMA-KSB, NIMHANS, and IPS-KC. So, and we have got a very good response. And in fact, last week when I traveled in Belgaum also, some of the members who happened to participate were very, very appreciative of this wonderful move. And especially some of the young doctors who had worked in COVID, they were very happy to share that they had an opportunity to interact with the counselors or the professionals who were on the other side of the helpline. So especially the Manovani, which we all have started, and also last week's topic also, and they are eagerly waiting to see some good, other better and good topics to come up. And I think we have to work on that also. With this introduction, I would just hand over the stage to once again Dr. Deepak, and I welcome the speaker and everyone for this webinar. And over to you, Dr. Deepak.
Good evening, everyone. The motive of starting this series of webinars is well explained by most of the people who spoke before me. And Dr. Somsekhar Vijay has clearly explained regarding treatment gap. The whole idea started about a couple of months when we lost a doctor who committed suicide. So there was a strong notion that we should do something more for our own doctors and educating them, in turn educating them regarding psychiatric problems, psychiatric illness, ways of managing stress. It would not only enlighten the doctors, it would indirectly help all the patients and society at large, because once the doctor is empowered with basic psychiatric knowledge, he could easily pick up some psychiatric diseases, which is probably with the pandemic, the number of psychiatric illness have gone up drastically. And in fact, the psychiatric pandemic is going on for more than 5 to 10 years now, and it is not gonna come down. So telling this, I would like to introduce chairperson of the day. I welcome Dr. Harisha Dellantabettu to the program. He is Professor of Psychiatry at KVJ Medical College, Sulya. He is co-chairman, Forensic Psychiatry and Law Subspecialty of Indian Psychiatry Society, chairman of Academic Subcommittee, ima-ksb, core committee member of Psychiatry Cell, ima-ksb, past president of Indian Psychiatry Society, Karnataka chapter, is also past vice president of Indian Medical Association, Karnataka chapter. I welcome you, sir.
Thank you.
And the person of the day, speaker, Dr. N. Manjunatha, is an associate professor at Department of Psychiatry at NIMHANS. He has done his MD from Central Institute of Ranchi, Central Institute of Psychiatry, Ranchi. Currently, he is associate professor of psychiatry at NIMHANS. Okay, he has worked in multiple prestigious institutions before. He has in total 15 projects currently under him. He has multiple peer-reviewed journals published. We fondly call him Manjana in our Indian Psychiatric Society. Very jovial, very down-to-earth person. Now, I hand over the dais to Dr. Harisha Dellantabettu, sir, to take it forward.
Thank you, Dr. Deepak from Chittoor.
Hello.
Unmute ಮಾಡಿ ಸರ್.
ಒಂದು ನಿಮಿಷ. ಇದು ಕಳೆದ ಒಂದು ಇದ್ರ ಬಗ್ಗೆ ಈ ದಿನದ ಅಧ್ಯಕ್ಷರು ಶುರು ಮಾಡೋದಕ್ಕಿಂತ ಮುಂಚಿತವಾಗಿ ಕಳೆದ ಒಂದು ಸೀರೀಸ್ ಬಗ್ಗೆ ಹಿಂದಿನ ಚೇರ್ ಮಾಡಿರ್ತಕ್ಕಂಥ ನಮ್ಮ ima-ksb ಅಧ್ಯಕ್ಷರಾಗಿರ್ತಕ್ಕಂಥ ಡಾಕ್ಟರ್ ಕಾರಂತ್ ಅವರು ಹಾಗೂ ಟೆಲಿಮೆಡಿಸಿನ್ ವಿಭಾಗದ ಡಾಕ್ಟರ್ BMS ಅವರು 1-2 ಮಾತುಗಳನ್ನ ಹೇಳಬೇಕು ಅಂತ ಕೇಳ್ಕೊಂಡು ನಂತರದಲ್ಲಿ ಇವರು ಹರೀಶ ದೇಲ್ಲಂತಬೆಟ್ಟು ಸರ್ ಶುರು ಮಾಡ್ಬೇಕಂತ ಒಂದು ಮನವಿ. ಕಾರಂತ ಸರ್ ಅಂಡ್ BMS ಸರ್.
ಮೊದಲು ಯಾರು?
ಕಾರಂತ್ ಸರ್.
ಓಕೆ. ಕರಾವಳಿ ಅವರಿಗೆ ಮೊದಲು ಪ್ರಾಶಸ್ತ್ಯ ಇರ್ಲಿ. ಮಂಜುನಾಥ್ ಅವರ ನಾನು ಐ ಹ್ಯಾಡ್ ಅನ್ ಆಪರ್ಚುನಿಟಿ ಟು ಇಂಟ್ರೊಡ್ಯೂಸ್ ಡಾಕ್ಟರ್ ಮಂಜುನಾಥ್ ಲಾಸ್ಟ್ ಟೈಮ್. ಫ್ಯಾಂಟಾಸ್ಟಿಕ್. ನಾನು ಅದನ್ನ ನಿಮ್ದು ಕಡೆಗೆ ಬಯೋಡೇಟಾ ಮರದಿವಸ ಫುಲ್ ಓದಿದೆ. ಅದರಲ್ಲೇ ಸುಮಾರು ಸಬ್ಸ್ಟೆನ್ಸ್. We have a very good, it was a very good program, and I'm very happy to see you again. And I wish the webinar all the best. Thank you.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಟೆಲಿಮೆಡಿಸಿನ್ ಸೆಂಟರ್ ನಿಮ್ಯಾನ್ಸ್ ಬ್ಯಾಂಗ್ಳೂರಿಂದ, that the association between IMA and the NIMHANS. ಹಾಗೆ ಹೇಳಿದಾಗೆ there is 80% treatment gap. 80% ಜನ psychiatric patients treatment ಸಿಗ್ತಾ ಇಲ್ಲ. So invariably the government, from the government perspective, they are doing various things to reach the treatment to the common man. ಅದು ಯಾವ್ಯಾವ ರೀತಿ ಅಂತ ಹೇಳಕ್ ಆಗೋದಿಲ್ಲ. They have done various things which, as allopathic doctor, you may agree or you may not agree. But at this point of time, we have to take psychiatry to the common man. ಅಥವಾ ಮಾನಸಿಕ ಕಾಯಿಲೆಯ ಟ್ರೀಟ್ಮೆಂಟ್ ನ ಕರ್ಕೊಂಡು ತಗೊಂಡು ಹೋಗ್ಬೇಕಾಗತ್ತೆ. So for that reason, this is the endeavor, and this is the, I think, second seminar. So all the best, Dr. Manjunath, and all the best for everyone.
Thank you, sir. Over to Dr. Harisha, sir.
Thank you, Dr. Vijay, sir. I would like to recognize the presence of the IMA-KSB President, Dr. Venkatachalapati sir, the immediate past President, Dr. Madhusudan sir, and I also recognize Dr. Napur sir, the Honorary General Secretary, Dr. Prasad, and we have very enthusiastic young generation from NIMANS who are equally interested in IMA also. So we welcome all of you on this occasion. I also recognize many postgraduates joining this webinar. Welcome you all. So coming to the subject, we have about 6,000 to 7,000 registered psychiatrists in India, and we have a lot of workload. And it is necessary to sensitize all doctors regarding the psychiatric illness. It is said that about 40 to 50% of the all OPD consist of illnesses, morbidities with the psychiatric illnesses. So basically, there is a huge chunk of untreated psychiatric morbidities in the community. So it is the right time to sensitize all the doctors regarding the psychiatric illness. It is also the vision of WHO to integrate mental health into primary health care facilities, services. And this is happening for the past 20 to 25 years, and it is going in a good way. Now that all the primary health centers are providing psychiatric treatment also. In addition to this, the regulation, now it is NMC, that many postgraduates are coming from medical colleges. So the manpower in psychiatry is slowly increasing. So that is also a good sign. So in this regard, a renowned psychiatrist associate professor has got some initiative from NIMANS. We see doctors, Dr. Badamat, Dr. Naveen Kumar are very much enthusiastic regarding. Many young doctors are coming from NIMANS who are involved in, many innovative initiatives. So one such initiative is what Dr. Manjunath is coming out with. He has worked at Mandya regarding this program. It is about the digital training of MBBS doctors, both government and non-government doctors. And by this way, we can provide better psychiatric treatment to the patients at the primary health care level. And today's talk is mainly on how effective is this particular program is. So Dr. N. Manjunath is going to speak about this particular subject, and now I request sir to go ahead with this presentation. Thank you.
Thank you very much, sir. Can I start, sir?
Sure.
Yeah, thank you very much. On behalf of NIMANS, thanks to IMA Karnataka branch and IPS Karnataka chapter to giving this opportunity for us to integrate with the IMA doctors more than psychiatrists. So I would. Yeah, I think slides are visible, right, sir?
Yeah, we can see the slides.
Welcome to Psychiatry for all IMA doctor, that is called paid webinar series. Not really money paid, it is just an acronym which we have derived. This is the second topic, is the primary care psychiatry program designed by NIMANS is effective? Because this topic, we have actually in NIMANS has been working in primary care for quite long, more than 2-3 decades. But we have made it some kind of specialized program for last couple of years with the integration of telemedicine technology. So we kept it as some kind of primary care psychiatry program. Benefit from this paid webinar series, I would say that to all IMA doctor can enjoy better personal and professional, personal and family life, and they can enjoy better professional life and possible reduction of medical legal litigations, do occur after these webinar series. Whom did this primary care psychiatry program we designed? Actually, Telemedicine Center, Department of Psychiatry, NIMHANS designed this program exclusively for practicing MBBS doctor. So practicing means they should finish MBBS. They should start seeing their clinical practice after 1 or 2 years. That kind of doctors we designed this program. And till now, we have implemented and benefited by many doctors. I would say the number 426 MBBS PhD doctor across Karnataka, across all districts in last 2 years. 20 MBBS PhD doctors of Uttarakhand in 18 and 19. And 20 MBBS PhD doctors of Bihar is ongoing now. Some of them are joined in this webinar series. And I thanks for the Bihar doctors who have joined here with there is some time they have taken out. And 25 MBBS doctors of Uttarakhand in next month we are starting in collaboration with AIIMS Rishikesh. And 25 MBBS doctor PhD doctors of Goa, which is upcoming. We may start in a couple of months there. So this program has really helped many of the doctors, and predominantly as now and 426 doctors across the Karnataka has got benefited. And not only doctors benefited, I am more or less sure that the patients whom they are treating are also getting benefited from these programs. And before I go in detail about this, some of the things which we need to know: what is MBBS doctor they do practice, and what psychiatrists do, what is their practice. So it's a normal kind of practice because there are a lot of myths and realities are there. So first question is often doctors ask, do MBBS doctor come across psychiatric patient in their general practice? This initially when I started working in primary care, the response would come up, sorry, how the patient could or psychiatric patient namatra. So till then it has gone to 20, 30 kind of things. Overall, the number of MBBS doctor who treats in general practice, the psychiatric patients are around 30 to even up to 50%. So now it comes to 50%. In that case, some of the patients, if you think that answer is no, then some of the questions I would ask doctor that what are the common symptom presentations of your outpatient consultations? So our response is coming like this. Sir, actually, multiple pain, ache, sleep disturbances, and acidity problem. These kind of problems are coming. So next question I generally ask them, what are the diagnoses? So diagnosis, definitely when I ask question for diagnosis, very few doctors gives responses. And coming to treatment, I am sure no doctors will send the patient without prescription, even though they are not fully aware of the diagnosis of psychiatric condition in the treatment which they are doing. So definitely they are doing treatment, and what kind of treatment they are giving. So it is more of symptomatic treatment and painkiller, proton pump inhibitors, H2 blockers, IV fluids, painkillers. These kind of treatments has been given. That is what doctors, many of them says. And what is the short-term, medium, and long-term course and prognosis of these treated patients? What generally happens with these kind of patient is that some of the patient, I am not saying every patient, some of the patients will come to psychiatrists very late. Some, even I will tell you, it is more than 10 years of illness. They got treated by doctors, nearby family doctors, all this. After 10 years, they come to psychiatrists, even at NIMHANS. So the 10-year, one or other kind of treatment has been given there, but there is not much benefit. And so you just imagine what is the time, so much of time has gone, few years has gone up patients, and what is the cost involved in care of these patients. Cost not only for doctor consultation fee, and not only of the medication which they prescribe, you think of their traveling charge, food charge, and the disability on which the symptoms is appeared, where he is not able to productively work. So much of money cost is wasted by these kind of patients. Okay, at the end, are these doctors are happy and satisfied with their treatment? Majority of them are not in that way. Finally, our MBBS doctors are happy and satisfied with their general practice. I am talking in terms of treatment and improvement with these treated patients. Many of the doctors would say no, and I will say how they identified. The moment some of the patient enters in the consultation room, you feel a very disgust. Oh, bandala payuno. Those kind of patients are there, so they are not also really satisfied. These are the responses which I would get with the MBBS doctors whenever I go and take some sessions with them. If I think that is the answer, what is the percentage which I already said, nearly 30 to 50%. And good thing about these patients that all these patients are coming to all these doctors on their own. Often the one of the myths about psychiatric patient is that psychiatric patient don't come to doctors. But majority, every patient will come to primary care doctor or MBBS doctors on their own. This is one of the good things. And what is a common diagnosis of these psychiatric patients? I would say that is common psychiatric patient. If you ask to name some psychiatric disorder, depression, anxiety, somatization, tobacco, alcohol, these kind of problems are very, very, very common even for MBBS doctors. But just these are the name, but how to diagnose, how to do prescription, this is not being taught during our MBBS. So core reason for this kind of and I was just telling Dr. Bijal also, there is a treatment gap at community and there is a treatment gap at MBBS doctor's clinic. With the MBBS doctor clinic at primary care, we call it as a functional treatment gap because the function is not there. It is a dysfunction at primary care level. I would say that the core reason is there is an underdiagnosed, under-treatment of psychiatric disorder by MBBS doctor. I am not blaming any MBBS doctor. I would say that it is a poorly synthesized and mismatched MBBS curriculum of the psychiatry is the reason for this kind of problem for patients are not getting benefit at PSC level. Then what is the existing MBBS course curriculum in India? Actually, we have been trained in tertiary care hospital by specialist faculties in Western-oriented, highly specialized textbooks. This is the reality. Naturally, MBBS doctors are inclined to tertiary care management than primary care management. Just imagine your final year MBBS and MBBS exam, where what kind of long case and short case which you have been given, and I am sure those kind of cases which you are not many of us has seen after MBBS. So this kind of training has been done in our MBBS. So then MBBS are expected to practice in primary health care after that and private primary care. This is an unfortunate situation, but that is a reality. So ideal MBBS curriculum should match the patient profile of the primary health care. That has not happened till now in India. Hopefully that should that should be worked out later. Now this is MBBS doctor's practice. Now we should discuss about how psychiatrists practice. Are the psychiatrists are medical MBBS doctors? So some of the time, often doctors will come very, very politely ask, "Sir, have you done MBBS?" So it is an unfortunate situation. Yes, it is rare also. Yes, but this is reality also. It is yes. So we have to tell them, yes, we have done MBBS doctor. The next question, some of the people will ask, "Sir, what is the difference between psychiatrist and clinical psychologist?" I would say that the psychiatrist or MBBS doctor and clinical psychologist are not the MBBS doctors. They are not medical doctors, but they come from a BA background and MA background or MSc background and with a psychology. Then they enter in a clinical psychology in MPhil. That's how they enter in this clinical setup. So how do psychiatrists practice their consultation? So often one of the myth with the people and people, including MBBS doctors, that, "Sir, you do counseling for all patients, no? You don't prescribe medication." So we say that, see, no, we do practice, and 95% of my patients which I see consultation, I give medications. More than 95, even 99%. So when we say that, then question comes, what kind of medicines we are giving? Oh, it is addictive, no sir. Sedative, no sir. So these kind of things. So we have to tell even some of the lay people, including MBBS doctors. At the end, MBBS doctors are so layman when they ask these kind of questions. And do psychiatrists prescribe medicine for psychiatric disorder? Yes, we do prescribe medications for all psychiatric disorder, majority of the psychiatric disorder. What kind of medicine? Sedative, hypnotics, And definitely, yes, we do prescribe sedative and hypnotics for a secondary reason, not for the primary reason. And I would say that the sedative which we prescribe is very, very less addictive than other doctors. I will discuss about this thing in maybe next session. Do psychiatrists prescribe non-sedative, non-addictive, evidence-based pharmacotherapy medications? In some sessions, somebody has asked, what is it some kind of placebo response or not? No. Actually, we will say that all medication which we prescribe is more than the placebo response. All are having better results in RCT proven medications. What you people call evidence-based medicines, which we do practice in day and out. And unfortunately, many of the MBBS doctor doesn't know, especially maybe with our contemporary. And what is the usual time frame of the psychiatric OPD consultation? This is another question which you ask. So what do you think, how long we'll see each patient? Then they say they start with 30 minutes, 40 minutes, maybe 1 hour, sir. It is almost impossible in India. Not only in India, even in the US, some of the psychiatrists say that our majority of our consultation is pharmacotherapy based and very brief. And I would say that this is, for example, I am seeing around 25 patients in 3 to 4 hours. So imagine how much time we give for psychiatric patients. So it will not be more than 10 minutes in an average generally. So we will, if I spend 10 minutes with each patient, it is a luxury for patient, and I will be more comfortable of doing clinically. But that also doesn't possible. Sometimes we have to push the patient in 5 minutes with some kind of a diagnosis and prescription. Not only here, we do prescription-based practice and some kind of very brief, ultra brief counseling, which we do with patients, which we'll discuss later next session. Do psychiatric practice with psychotherapy only or with medications? See, psychotherapy is one of the things which people talk. It is a counseling. It is a specialized counseling for treatment purpose, which we use. But often, many of the time, in my understanding, is that we have not, very rarely we use psychotherapy standalone with the patients. More than psychotherapy, wherever we use psychotherapy, 99% of patient is already we are giving prescription also medications. So in that case, psychotherapy is often psychiatrists don't practice because of the time consumption on which they take. Not only time consumption, many of our Indian patients doesn't prefer psychotherapy also, because they want pills and they want rapid responses. Both of things are not possible with psychotherapy. And there are some patients who come specifically only for psychotherapy. That time we entertain psychotherapy. Otherwise, with a busy practice, even at NIMANS, we will not be able to do psychotherapy for all the patients who consult us. So the crux of this thing is that we do practice pharmacotherapy with majority of the psychiatric disorder which we come across. Can MBBS doctor manage psychiatric patient in their general practice? If you think no, then as I said, it is 30 to 50% of their patients are having psychiatric disorder. Our MBBS doctors are afford to lose these general practice patients to send to psychiatrists. So it is also not possible to refer all patients to psychiatrists. Just imagine how much psychiatric patients load is there. Imagine 30% of MBBS doctors each day in India having psychiatric problem. Do you think we can get that much of psychiatrists to treat those patients? It is not possible, and it is not required at all. In another word, can you imagine any government in the world afford to have a required number of psychiatrists for this kind of prevalence which is there in the primary care? No country in the world can afford to have adequate number of psychiatrists to treat all their psychiatric disorder in their country. This is another reality. Is the psychiatrist only need to do psychiatric conditions? No, definitely no. And I would always say that all MBBS doctors are equally competent to treat psychiatric disorder which they reach in their consultation, especially to provide primary care treatment. The primary care treatment, in the sense, I'll tell you what is the primary care on which we always talk here is a first line treatment. The first line treatment is we equate with the primary care. If answer is yes, then what are the roadblocks to provide a primary care psychiatric care at their general practice? I would think that, as I said, MBBS curriculum doesn't have equal weightage of, say, a patient's profile which they see at primary care. So that is the one crux. If MBBS doctor began to treat psychiatric patients in their general practice, some of the psychiatrists have concern about this kind of thing, is that, oh, we may lose our practice. Definitely, I would always say that definitely it is not. If MBBS doctor starts treating psychiatric patient, in fact, there will be paradoxical increase in patient load among the psychiatrists. That is more or less happened in Karnataka, because doctors, every patient which they start first line treatment, and patients may not improve, at least may not improve, and they may not able to diagnose the way we psychiatrists diagnose at primary care level. So ultimately, the number with the psychiatrists will increase if we try to do MBBS doctors. And psychiatric disorder alone in India, in our country, is that 13 crore people in India currently is having psychiatric disorder. It is impossible for psychiatrist numbers to less number of psychiatrists to treat. So, what will MBBS doctor gain by providing primary care psychiatric treatment at their general practice? So that we will open it to you, all of you, to just imagine what is the benefit they will have. And as I said, we have already designed a highly specialized primary care psychiatric curriculum program. And the curriculum, how we design. When we design anything new, we need to have some kind of guiding principles. So these are the 10 guiding principles on which we have designed this primary care psychiatric program. One of the things is a training location. I will just show you that part in next slide. Then coming to training methods, that is also, I will show it in the next slide. And then comes to integrate with the practice style of the doctors. One of the important practice style of the doctors in India is a consultation time. Every doctor in India is a busy practitioner. So we cannot afford to train them in a longer period of time, and they cannot spend too much of time on with each patient. Recently, I think last year, there is a research as published in BMJ journal saying that across many countries they have published, and in India, each general practitioner spending time with patient is 1.3 minutes. So this is the research says. So if we train doctors, how much consultation time? So they should be able to diagnose and treat in 2 minutes time, maximum 3 minutes. Okay, give them 5 minutes time. Within 5 minutes, their patient should be diagnosed and treated by them. So we have to train each doctors like that. Otherwise, they say that it is not possible with that, you do. We will send to you, you do. So we have developed this program to integrate these concerns with very important factor. Within 2 minutes or 3 minutes, each MBBS doctor can diagnose and treat psychiatric disorder at their level. So this is one of the things. Another practice style of the doctor is to develop simple diagnostic and treatment algorithm. So here, as I said at initial point of some of the slide, is that we don't bother about diagnosis much. Often we diagnose with a symptom-based and sign-based diagnosis and some kind of treatment. To make it very simple, paracetamol is given for all febrile illness, irrespective of etiology. So we need to develop some kind of simple algorithm keeping this paracetamol for all febrile that we have designed in this psychiatric curriculum. And target population, which at the beginning we have focused only on adult patients, and we are not biased about pediatric patient. I would say why one of the reason is that one is less number patients goes to MBBS doctor. Another thing, majority of the child psychiatric problems need more than medications. It needs psychotherapy or it needs counseling, which is a time consuming. I'm sure none of the MBBS doctor in India have such luxury time to spend 30-40 minutes with each patient. So we thought we'll begin with this focus first, and then we'll go next for pediatric whenever doctors are comfortable with adult patients. And next we use the principle called prescription-based integration. So here I would say that prescription, as I discussed, every MBBS doctors are sending patient with prescription. So it means that some amount of treatment is given. So what we have focused here, that substituting their prescription with the evidence-based treatment as a medication first approach. what I see, what I give prescription for depression patient at Niman, same medication should be given to patients where MBBS doctors are seeing depression. So that kind of approach and prescription should substitute with what they are giving. As I said, symptomatic treatment should be replaced with evidence-based treatment. That's what we are focused, and we are more or less reasonably succeeded in that way. And we are focused on highly prevalent psychiatric disorder in the primary care. As I said, we have more than 99 to 100 psychiatric disorders in our textbooks, but we are focused only on 6 psychiatric disorders. Those are highly prevalent at primary care to train the MBBS doctors. And another thing which we have designed is a point of care manual. Point of care manual is majority of the time textbook and manual, which we have multiple pages, very thick book. And I am sure once the doctors had taken it in their hand, they never opened up in their 1 or 2 years. So we did not want that kind of situation to arise. We have prepared only 8-page manual for doctors, which is required for 6 diseases in their patients to treat. That what is given in manual is everything which is required for the patient from entry and to exit point, including prescription, ready-made prescription, which we are given to the doctors in this manual. This detail about this manual next session we will discuss. And 9th guiding principle was to empower doctors to provide first-line treatment to general patient who has psychiatric disorder. As I said, primary care for us is to make MBBS doctor to do first-line treatment for their general patient wherever the psychiatric disorder is there. In another word, what I prescribe for depression in a man, same treatment should be given by MBBS doctor at their clinic. This is our way of understanding. Then we have developed outcome indicators, whether the training program is really helping doctors or not. That kind of quality indicators we have developed, what we call as primary care psychiatric quotient and translational quotients. I will talk at the last slides which we have. Next, when we think of training an MBBS doctor, this is the age-old method has been used. If you see this thing, I used to do earlier when I started doing my DPM also, we used to train MBBS doctor, calling them in a room, 20, 30 doctors, whole day, Monday, 2 day, we used to give people PowerPoint presentation, show some video, those and give some books and these kind of things. And many of the time we found that doctors are happy with the whole day program, but that is not helping the doctors when they see the patient in their clinic. So there was some kind of knowledge to skill gap was there, which we call as a translational quotient. So the training program of classroom training did not have good translational quotient. They had to transfer to the clinical skill required for doctors when patient enters in their consultation room. So what we did is the innovative work which we have worked at NIMANS. And this is one of the crux of this primary care psychiatric program. See, this is the card. If you just see, I am sitting with another PhD doctor and seeing the patient, I am discussing with her and to train the and training her what question to ask, how to make diagnosis, how to write prescription. And all these things has not taken more than 10 minutes at any point of time. This is what we call as on consultations training. So this is OCT and I sat with them physically. So we called it in-person on consultation training. Next, I will not be able to go and sit with all MBBS doctors, and neither me and any of my colleagues cannot go every time whenever we think of training to MBBS doctor. So we have used the technology for this thing, is this telemedicine technology, especially video based. So what we did is that we use the telemedicine to train sitting at our NIMANS and getting a live streaming of a consultation of the doctors. And we trained them almost similar to in-person on consultation training. This is the innovative work which we have done. I proudly say that probably it is the first in the world. Next comes, as I said, it is a small manual and this is colorful first page, but overall the schedule of these books is around only 8 pages. So 8 pages is sufficient for practicing MBBS doctor to give first-line treatment for their psychiatric patients. So these are the 21 questions which we have designed, and keeping with our culture, way we ask question. These are the question is not there in any Western books or any other country. This is designed by our own experience with lot of feedback from MBBS doctor and some residents, some nurses, we asked them to ask this question, and some of these kind of we have designed, and we have validated this thing at Ramnagara PHCs. So this questionnaire is given in the clinical schedule. This is called clinical schedule for primary care psychiatry. We simply call it as a CSP. Then comes we have designed a few programs of primary care psychiatry program, and today I will talk only one program which we proudly talk about. It is a diploma in primary care psychiatry, which is a prototype course. We have other course also, but I'm talking about a prototype course which demands. This is a 1-year program. This is a modular based, and it is a part-time course, digitally driven and flexible curriculum. Just imagine in 365 days of this program, 360 days, doctors are not with us physically. So initially only few days they will come to us and they get some kind of orientation, sensitized, they go back, and all training happens in a digital way. And we use some of the principles of andragogy, adult learning. We cannot teach like we are teaching with MBBS doctor, because some of the time I found that some of the MBBS doctors are senior to me, not only in age, in their experience as well. So so we have to use adult learning principle. Then E to E approach. So the training program often in our MBBS, even in MD or even MCH or MS, it is very, very small part of the things which we train. For example, we will train our MD resident. When patient comes, what are the questions to be asked? We'll just train them that question, and we will not bother about other things. So what we have done in this training program on consultation training is entry of the patient to exit of the patient. Whatever I do with patient, everything will be taught to MBBS doctors within 5 minutes of clinical consultation. Then at the end, prescription writing. Some of the doctors have had difficulty to write the pharmacotherapy medication which we prescribe. Literally, I have to handhold them to write prescription to begin their substituting their practices. And this diploma in primary care psychiatry program has a 6 module. One module is a syllabus module which I have shown. It has an 8-page clinical schedule of psychiatry. There is a basic module. This is on-site where the doctors come with us at NIMHANS, or equivalent sites where we train them 5 days, morning in the clinical setting and afternoon in the classroom setting. And tele-OCT module where, as I shown the figures there, this is the training which do occur with their own patient, own clinic. We are not showing my clinic, my patient. I am training them in their own patient, their own clinic. So there will be 3 sessions at 1st, 3rd, and 7th week of the training. So a total around 30 to 50 general patients, we train them to pick up psychiatric patient, what question they need to ask, how to make diagnosis, how to give prescription, what to tell to patients after writing prescription. Everything will we teach in tele-OCT. Please remember, tele-OCT is the module where we train in general patient, not the psychiatric patient at all. And collaborative video consultation is another module where primary care doctor, MBBS doctor brings of their own selected patient and discusses that for a better treatment. Often when the tele-OCT trained doctors are there, when they come with CVC, they have very, very small doubts at an initial point of time. For example, if they found that the patient is having some depression, but he has some kind of tension, what to do? So we will just tease it out and tell that your diagnosis is right, the symptoms is not make major difference. Why don't you go ahead with your own treatment? That kind of approach. Here in CVC, 95% of the patients are having psychiatric disorder. But in tele-OCT, less than 50% of patients are having psychiatric disorder. Another 50% of the patients are having general medical problem, where we tell the MBBS doctor to treat the way they used to treat. And in fact, we ask them how they're treating. If they teach us also, we will also get to know that some kind of reciprocal learning do occur in that tele-OCT session. Then comes virtual classroom module, where this is a 1-hour classes on virtual mode like this, which we are discussing. 1 hour in a week, where a MBBS doctor presents their seminar or case conferences. That these case conferences are real case conference which they have cases they have seen in TeleOCT or CVC. So where these case conferences are verified case conferences by a psychiatrist. And seminar is also a verified seminar where one of the psychiatrists will sit with them, maybe doctor, help them to prepare seminar and present. So here we are building up their confidence in talking psychiatric terminology with other doctors. And some of the expert session will also be there in this module. Another module called public health module, we encourage them to do one homework assignment. One is public talk about psychiatry, any conditions, anything. In police, teachers, or anything, they have to go and do the public talk, and we request them to send 3 minutes clip to us to see what they really spoke. If they need help for this public talk and all, we used to give them, we'll try them before they go there. And one of the other assignment is a public health education material. They have to design of anything related to psychiatry, maybe tobacco, suicide, depression, anxiety, anything which they did, and they can utilize in their own clinic, or sometime if it is very good, we will ask other doctors to use with their permissions. And assessment, and is there any quality control for this program? Yes, we have quality control throughout the year and at the end of the year also. Throughout the year, what we call formative assessment, at the end, as usual, our end of the exam, final exam is called summative assessment. In formative assessment throughout the year, we have 10 criteria to assess the quality control. As I said, one case conference they have to present, one seminar they have to present, and collaborative video consultation they have to discuss with us in the telepsychiatrist. There are 25 patients. Out of these 25 patients, 5 patients, they have to do 6-month follow-up with us. And there is a total weekly, monthly patient audit. It is not weekly, it is a monthly audit of total and psychiatry patient. They have to give self-report in a Google form. And we used to ask them prescription audit of their psychiatric manual, how many antidepressant they prescribe, or how many antipsychotic benzodiazepine they give prescribed. Those kind of things we will take in Google Forms. And virtual classroom attendance is about more than 60% has to be there. And TeleOCT, the training which we do TeleOCT, we have evaluation session every 3 to 4 months. So in that 1 year, there will be 3 evaluation. And one of the beauty of this quality program is that probably it has never been done anywhere in medical course, is that TeleOCT, the way that a real consultation, one of the psychiatrists who has not trained this person, that doctor, will sit with him to see 10 consecutive random general patient, where the examiner will see whether the doctor is asking psychiatric right question at right appropriate, whether he's thinking the way algorithm is maintained, or whether he's prescribing properly or not. Those kind of assessment we have criteria where it will be assessed every 3 to 4 months. This is one of the beautiful way of assessing throughout the year. Now every 3rd month you will have a TeleOCT evaluation. And as I said, delivery of one public health initiative, one public health education material. This is the formative assessment. Next come to summative assessment. Proudly I would say that probably in Indian medical education, we have created a history that we have conducted on-camera exam for these courses for theory and clinical exams. How did we conduct? Is that the theory was 2 for paper, 20 MCQs, 30 short essay question. MCQs was in a Google Forums in 1 day, and next day was short essay question. It was 6 questions and 5 marks. 5 from clinical schedule, which we have given here, that 8 page. 1 question from other classes which they have undergone. Then coming to clinical, as I said already, TeleOCT evaluation every 3 months we do. Same thing which we do at the end as called a clinical examination in their live consultations with the 50 marks as a criteria. And at the end, outcome and effective indicators, and this was the initial first batch doctors at Uttarakhand, where primary care psychiatric quotient which we have calculated, it is nothing but number of psychiatric patients out of their general patients. So here 19,670 general patients they had seen, out of which 2,182 psychiatric patients they are diagnosed. So it is primary psychiatric quotient was 11% or approximately. Acceptable primary care psychiatric quotient is around 30%, which, and with our consensus we have desired. Still they are far from it, but it is the beginning. just imagine that 11% of that patient has got treatment as a psychiatric patient with medication. This is also one of the biggest achievement, the way we feel. Another thing is that this, yes, one of the limitation of the primary psychiatric quotient is a self-report. And another quotient which we said, that tele-OCT evaluation which we do here, and where 10 patients will be seen consecutive general patient, where we assess whether they are psychiatric skill which we teach, whether they are appropriately using or not, and we score them with 100% marks. Where here these course doctors are scored 70% on an average at 6 months and 76% on an average at 9 months. So the skill which we are trained in the course has retained even at the end of 9 months. And I am sure tele-OCT examination score is also almost similar that. So in that case, skill which we are, the knowledge which we teach, skill we are transferred is retained at the end of the 1 year. And it is reflected in their self-report as well. And coming to Karnataka doctors, where I said 426 doctors or PSC doctors across all districts in Karnataka we have trained. It is a pan-Karnataka program where we call as KTM program, Karnataka Telementoring and Monitoring Program. We are last year and this year we just recently concluded. It is a training of trainer version of primary care psychiatric program where we have trained all DMHP psychiatrists of the Karnataka, 36 DMHP psychiatrists. We have given them a certified trainer certification. After training them, in turn, they have trained 426 PSC doctors in the Karnataka. How did we do training of trainer? This is also one of the innovation is that first session I sat with the MBBS doctor and I have trained the MBBS doctor and I asked them to psychiatrist to see. Next session, I asked psychiatrists to try the way I tried in first session. Third, they will be independently doing. So this is a pan-Karnataka program. Then this program has got some of the recognition on some of the awards. Business World has given a Digital India Summit Award in 2018. Digital Innovation Award at Villamal Healthcare Innovation Award in 2019. And K.C. Dubey Award from Indian Psychiatric Society at last annual conference in 2020 at MOOC, Kolkata. And we have mentored and collaborating with AIMS Rishikesh for DPCP course. In fact, the DPCP course which we are doing at NIMAN, same thing is being recognized at AIMS Rishikesh by their governing body. And this year, next month, they are starting DPCP course. We are mentoring and collaborating with them. Thank you very much. And now it's open for clarification. I would request moderator, chairpersons to take over further.
Dr. Harish, unmute yourself. Dr. Harish. Dr. Harish, unmute yourself.
Yeah, I could do that. Yeah. Thank you, Dr. N. Manjunath, for your excellent presentation. And you have stressed on the magnitude of the problem in India. Basically, 13 crore population there who are eligible to take psychiatric treatment, and we have a very limited number of health professionals, especially psychiatric professionals, about 6,000. And it is high time that we have to train the MBBS graduates, and it's a good initiative that you trained basically DMHP psychiatrists, and to train in turn they trained many doctors. It's a good initiative and a good outcome. Now this particular topic is open for discussion. Before that, my question is the course offered by NIMANS, whether it's a recognized course from the university.
Sir, it is recognized by our NIMANS all body, governing body. Governing body of the NIMANS is the highest authority to recognize the course.
Yeah, I'll ask all of you to unmute. I'll allow you to unmute yourself. Yes, sir.
Thank you, sir. Thank you, Dr. Manjunath. So I have some 1 or 2 questions. So to get this DPCP course, only MBBS graduates or even those who are going internship, that is house surgeons, can they do this?
Unmute.
Sir, you have to unmute.
Unmute. Manjunath sir.
Sir, MBBS doctors who has practiced at least 2 years after MBBS.
Yeah.
Is the criteria.
Sir. And is there any fee for the course?
Sir, it is not open for private doctors. It is it is a sponsorship course by state government. State government has to fund for this, and we hire a psychiatrist to conduct this program.
Any age limit?
Doctors?
No age limit. It is deputation by state governments. And now we are seriously thinking of opening to all doctors, like other course.
One more point I would like to add, what Dr. Harish had asked a question. Harish Delantabittu. NIMHANS is now INI, Institute of National Importance, similar to AIMS. So we are governed by NIMHANS Act of 2012. That is a legislation passed by the Parliament. Section 24 and 25 of the NIMHANS Act. Whatever we give a degree, which is approved by the Academic Council, Board of Studies, and the governing body, that becomes the degree. And these INIs are basically to experiment what kind of diplomas or degrees to be given. So on that basis, Section 24-25 is honored, and no, what we call it as regulation bodies can deny these degrees. And it is clearly written, nobody can deny those degrees. And these degrees are basically for the purpose of reaching the public help. That is the idea.
And another thing, when we have given a diploma in primary care psychiatry certificate during a graduation ceremony, one of the things which we have put it that they cannot call themselves as a psychiatrist, but maximum some of them they can call as a primary care psychiatry. We have specialized, but they cannot call themselves as a psychiatrist. This is one of the things as governing body has suggested to put in certificate, that we have put it in the certificate also.
Sir, hello, Manjunath, Doctor.
Yes, sir.
Southern 30 to 50% of general practitioners case and psychiatric illness anta helidri. Is it really so? Yake psychiatric illness ashtu jasti agta untu because of all the physical illness? If the psychiatric illness contributes to 30 to 50% of the patient, is it really so? Are we over-diagnosing the psychiatric illness, or is it really happening nowadays?
Sir, I would think something like this. I did my MBBS from Bangalore Medical College, and during our internship in general medicine postings, there are a lot of patients used to come to general medicine in the OPD, and we have been trained by our PG residents saying that my kai no ante yaru bartare avrge diclofenac barabit kalasbidi anta. So those kind of patient, if you see that way, and if you see now when I sit and train with the MBBS doctor, I do realize it is even research says 30 to 50%, but when you sit really with MBBS doctor, even if you add tobacco, it will be more than 50%. This is the reality, because as I said, televersity is a reality show for MBBS doctors. One of the MBBS doctor whom I personally trained at Mandya district, he was quite senior to me, and he said that he is my BMC senior. He senior means 9 years senior than me. And I asked the question at the end, sir, Mujugara Anslilla, sir, and Chikoradana train Madaskotidin and that the response was amazing. The response was something like this. Il band kutkala tanka atara yochne itto, but ಈಗ ಅನ್ಸುತ್ತೆ ನನ್ನ ಲೈಫ್ ಅಲ್ಲಿ ಎಷ್ಟು ತಪ್ಪು ಮಾಡಿರಬಹುದು ನಾನು ಅಂತ ನಿಮ್ ಜೊತೆ ಕೂತ್ಕೊಂಡ. So these kind of responses comes, and I do tell doctors that you are not doing intentionally. That is the way we have been trained on during MBBS. So this televersity is a reality show. It is their own patient, their clinic, nothing to do with our patient and our clinic. We just tell them these are the questions, these are the things you need to diagnose, these are the things. And not only just one session, I would always say that why don't you follow up this patient for 3 months, 6 months and see whether these medications are helping or not helping. So these kind of experimentation will ask the doctors to do with. And coming to your response to your questions, I would think that the psychiatric disorder was existing earlier, but maybe we are training now and picking up by MBBS doctor and us is become more now.
One more additional we can add, Manjunath.
Yes, sir.
Many of our patients like anxiety disorder, gabri kaile, ಗಾಳಿ ಬಂದಿದೆ ಅಂತ ಹೋಗ್ಬಿಟ್ಟು ತಾಯ್ತಾ ಕಟ್ಸ್ಕೊಳ್ತಾರೆ. There are, if you go to any temple, any dargah, we see these many patients who are seeking complementary alternative medicine. Some of them do improve, some of them have a relapse. So many a time they either end up taking alcohol to regulate their anxiety, depression, self-medication start agutte. It may be various other, it may be tobacco, it may be various other. See, it's not only in India, it is 30 to 40%. Across the world, 30 to 40% of the primary care consultation has psychiatric, either as a standalone diagnosis or a comorbidity with the chronic medical condition like hypertension, diabetes, arthritis. That is one point. As the age increases, that is the number of age we are going to increase our mortality kadime aada hage, morbidity jasti agutte. That means if the people are going to stay for longer duration, invariably by the age of 65, 70, 80 ge, invariably chronic medical condition jasti agutte, then also the morbidity increases. Similarly, when we are going to come up with various treatment aspects for chronic conditions, invariably again morbidity increases. So for that reason, 30 to 40% of our population who come to various medical colleges or primary care have a comorbid psychiatric condition. If we don't address that, the quality of life will be very poor. That's the best way to put across. And of course, Dr. Manjunath also has added to this information.
Yeah, I have a point.
That typical psychiatric disorder which they see at their clinic, maybe next session I will describe with each illness so that it will be eye-opener for some of you where you have practiced after MBBS.
Yeah. Can I ask a question, sir?
Yes, sir. It's
Yeah.
for all of you, sir.
Yeah. Yeah. Because there should not be any choice. That's why I raised my hand.
Yes, sir. Yes.
Yeah. As you said, this training session is extended only to the government doctors. Am I right?
As of now.
As of now. Because what my suggestion to you people is 80 to 90% of the outpatient care and medical care is given by the private practitioners.
Exactly.
So that much of a burden they are taking it up. So why can't we extend? I suggest you to extend the training sessions to the general practitioners first, basically, because they are the family practitioners.
The basic module which I explained, 2 to 3 days, 5 days training program, we have already extended that only that basic module for private doctors also. Other thing we have not extended till now, and we are negotiating with our administrator, this thing to give permission for us to open up for private doctors, where we are thinking of requesting our administrator and governing body to start as a regular course twice a year for 10 doctors, and where maybe fees can be paid by the doctors yearly. Same money can be utilized for hiring one psychiatrist to train them throughout the year. So that kind of no profit, no loss kind of based thing which we are looking. If any demand comes from private, I am sure NIMHANS is the institute where we'll cater those kind of request.
How do you want us to get the demand?
Dr. Suresh sir can
just see, there is a writ petition in Supreme Court asking the government to increase the number of provide services for mental health care. Mental Health Care Act 2017 recent implement ಮಾಡಿರೋ ಪ್ರಕಾರ section 18 ಅದರಲ್ಲಿ ಏನು ಹೇಳುತ್ತೆ ಅಂದ್ರೆ government has a responsibility to provide mental health care for all person whoever wants treatment. ಅದು ಸಿಗ್ತಾ ಇಲ್ಲ ಅಂತಂದ್ರೆ compensation ಕೊಡಬೇಕು as per the law. This is the first legislation, health legislation. If the government doesn't provide anything, compensation to be given. COVID treatment ಸಿಗ್ತಾ ಇಲ್ಲ ನಿಮ್ಮ district ಅಲ್ಲಿ ಅಥವಾ ತಾಲೂಕಲ್ಲಿ, there is no compensation can be given. For a mental illness, there is no treatment available. Rehabilitation is not available in a district. Compensation will be given as per this legislation. So adadaga Supreme Court has issued a written notification to train all doctors. ಏನಕ್ಕೆ ಸರ್ ಇದು ಡಾಕ್ಟರ್ಗೆ ಯಾಕೆ ಟ್ರೈನ್ ಮಾಡಬೇಕು? ಸಿಂಪಲ್ ಕ್ಯಾಲ್ಕುಲೇಷನ್ ಹೇಳ್ತೀನಿ ನೋಡಿ. ನಮ್ಮ ಹತ್ರ ಇರೋದು 7 ರಿಂದ 8,000 ಸೈಕ್ಯಾಟ್ರಿಸ್ಟ್ ಅಕ್ರಾಸ್ ಇಂಡಿಯಾ, ಅದು 138 ಕೋಟಿಗೆ. ಸೊ ಇಫ್ ಲುಕ್ ಎಟ್ ದ ಇಂಟರ್ನ್ಯಾಷನಲ್ ಸಿನಾರಿಯೋ, ಆವರೇಜ್ ಆಗಿ ತಗೊಂಡ್ರೆ 1 ಲಕ್ಷ ಪಾಪ್ಯುಲೇಷನ್ಗೆ 2 ಸೈಕ್ಯಾಟ್ರಿಸ್ಟ್ ಬೇಕು. ಹೋಗ್ಲಿ ಒಬ್ರು ಅಂತ ಇಟ್ಕೊಂಡ್ರು ನಾವು ಸೈಕ್ಯಾಟ್ರಿಸ್ಟ್ 1 ಲಕ್ಷಕ್ಕೆ 14,000 ಜನ ಬೇಕು ನಮಗೆ. ನಮ್ಮ ಹತ್ರ ಇರೋದು 7 ರಿಂದ 8,000 ಅಷ್ಟೇ. So 14,000, it is one psychiatrist per lakh. But if you look at the international standard ಪ್ರಕಾರ 10,000 ಪಾಪ್ಯುಲೇಷನ್ಗೆ ಒಬ್ರು ಸೈಕಾಟ್ರಿಸ್ಟ್ ಬೇಕು. ಹಾಗಾದ್ರೆ ವಿ ರಿಕ್ವೈರ್ somewhere around 1,40,000 ಸೈಕಾಟ್ರಿಸ್ಟ್. ಸೊ 1,40,000 ಸೈಕಾಟ್ರಿಸ್ಟ್ ನಾವು ಪ್ರಿಪೇರ್ ಮಾಡಬೇಕು ನಮ್ಮ ಇಂಡಿಯಾದಲ್ಲಿ ಅಂತಂದ್ರೆ, ನಮ್ಮ ದೇಶದಲ್ಲಿ ವರ್ಷಕ್ಕೆ 1,000 ಸೈಕಾಟ್ರಿಸ್ಟ್ ಬರ್ತಾ ಇಲ್ಲ. ಹೋಗ್ಲಿ 1,000 ಸೈಕಾಟ್ರಿಸ್ಟ್ ನ ಪ್ರೊಡ್ಯೂಸ್ ಮಾಡ್ತಾರೆ ಅಂತ ಇಟ್ಕೊಳ್ಳಿ, ಹಾಗೆ ಈಗ ಏನೋ ಮಾಡ್ಬಿಟ್ಟು. ಅದು ಮಾಡಿದ್ರು ನಮ್ಮ ಪಾಪ್ಯುಲೇಷನ್ ಕಾನ್ಸ್ಟೆಂಟ್ ಆಗಿದ್ಬಿಟ್ಟು ಯಾರು ಸೈಕಾಟ್ರಿಸ್ಟ್ ಸಾಯ್ಲಿಲ್ಲ ಅಂತಂದ್ರೆ 140 ವರ್ಷ ಬೇಕು ಆ ನಂಬರ್ಸ್ ನ ರೀಚ್ ಆಗೋದಕ್ಕೆ. ಸೊ ಇಟ್ ಇಸ್ ಸಿಂಪ್ಲಿ ಇಂಪಾಸಿಬಲ್. ಅದೊಂದೇ ಅಲ್ಲ, ಸೈಕಾಟ್ರಿಸ್ಟ್ ಆದ ತಕ್ಷಣ MD ಡಿಪ್ಲೊಮಾ ಮಾಡಿದ್ರೆ ನೋಬಡಿ ವಿಲ್ ವರ್ಕ್ ಇನ್ ದಿ ಪ್ರೈಮರಿ ಹೆಲ್ತ್ ಕೇರ್ ಸೆಂಟರ್ ಆರ್ ರೂರಲ್ ಏರಿಯಾ. ಸೊ ವಿ ಹ್ಯಾವ್ ಟು ಗೋ ಅಂಡ್ ರೀಚ್ ದಿ ರೂರಲ್ ಏರಿಯಾ. ರೂರಲ್ ಏರಿಯಾಗೆ ಬೇಕಾಗಿರೋದು whatever possible the government is discussing and they are trying to reach. So they are coming with innovative models which is working in various countries. So similarly it is being done, and I'll give you one of the best example which is being done is Chhattisgarh. Chhattisgarh we are now training all medical officers in Naxalite area, Buntar irbodu, various places where the local people are trained. It is called as assistant medical officer, 3 years MBBS course, which was banned by Supreme Court, but the state government said, "Namatra yaru illa, navu marthivi anta." We are training them along with the MBBS doctor. Our early results, Dr. Naveen illa illidra, I would have shared that these 3 years doctors who have been trained are doing excellent work in terms of diagnosis, in terms of prescribing, follow-up, and rapport with the patients. This is unfortunate. MBBS doctor who have been trained for 5.5 years do not have a good rapport with the patients, but these 3 years who have been trained are doing extremely well. But the results are very disturbing to know, but that is the results. We are further increasing the number of sample size to know why is this difference. So there are various innovative models are being developed. Nodi, it's simply impossible to increase the number of doctors or PG because the population is huge. UK 7 ಕೋಟಿ ಇದೆ ಅಥವಾ 6 ಕೋಟಿ ಇರಬಹುದು, ನಮ್ದಿರೋದು 138 ಕೋಟಿ. Imagine if you are the prime minister or you are the health minister, you have to deal this huge number where we have to reach the rural population. So I may be very passionate about being a psychiatrist. Only psychiatrist will do the psychiatry ಅನ್ನೋದು protecting the profession. But as we entered MBBS, ನೀವು ಯೋಚನೆ ಮಾಡಿ, MBBS ನಿಮಗೆ ಸೀಟ್ ಸಿಕ್ಕಿದೆ. when you entered into your MBBS college, what was your thought in your mind? Thought to reach to the rural population, ಎಲ್ಲರಿಗೂ ಸಹಾಯ ಮಾಡಬೇಕು. But once we become MBBS, once we become PG, we think of protecting our profession rather than protecting the public or the people with whom money we have taken this MBBS. And one example is I did my MBBS from KMC Hubli. 5,000 rupees was my what we call it as the bill, or what we call it as the fees which I paid. Now it is my turn to serve the public. Whatever the public is required, that we are going to reach. So invariably the government is doing all their best and we have to go with the government. And yes, we want to protect our profession, but that comes secondary. First is what is our duty towards the country or maybe the fellow human beings. Sorry to hurt some of the sentiments of my fellow colleagues who are there in the participant, but this is the way it is. The numbers, when we start thinking, they are very, very disturbing.
Yeah. Sir, ಧನ್ಯವಾದಗಳು.
Dr. Madhusudan sir, question.
Yeah.
Sir, if any private doctors want this course, please write to director of NIMHANS for requesting for this course.
Yeah, through IMA we can do it.
Please do it, sir.
Yeah.
Any request comes from anybody and NIMHANS will take up very seriously. Nothing will go unnoticed.
Yeah.
There will be serious thought will be given.
Yeah, taking further with Dr. Suresh Badamad, but unfortunately, lot of brain drain is happening in the psychiatry department. You have to accept it. Many of the outcomes from NIMHANS, they are leaving India. That has to be also be taken care. Am I right, sir?
I completely agree with you, sir. There is no doubt about that. But
that is coming down, sir, now. because many of the psychiatrists are getting good jobs reasonably and they are staying back, and those who are gone are also coming back.
See, hats off to you, all the people, all the psychiatrists who are there staying in India in the district level and taluka levels. Really, hats off to you. We owe our these things to you, and definitely we need to think in that direction also.
Just imagine, sir, in government of Karnataka, the DMHP psychiatrist, around 36 DMHP psychiatrists, they are given a job. Yeah. In fact, yesterday, there is one UK psychiatrist who was my student. He called me, sir, yadara DMHP lidre job kodsi na bandbidtini. So there are reverses also happening. There are opening ups are there in psychiatrists. So people are coming back, and it is not specific only to psychiatrists. Sir. All branches are going more in psychiatry. I agree that way, but that will be reversed.
Okay, sir.
What Dr. Badamat said, IMA has some reservation on 3-year course of MBBS and all such things, and it is actually some of the issues related to IMA. However, it will be discussed in the right platform. However, you said something about disturbing outcome. Actually, can you explain what is the disturbing outcome?
Because see, the people who have done for 3 years training courses are doing well, but not the 5.5. So that means there is some wrong in our training courses. Maybe MBBS, we don't know. Because the same thing what Dr. Manjunath heladina, ನಾನು again repeat ಮಾಡ್ತೀನಿ. ನಮ್ಮ MBBS books ಎಲ್ಲ foreign based, and ನಮ್ಮ MBBS exams are based on international books. ನಮ್ಮ ಡಾಕ್ಟರ್ಸ್ MBBS ಹೊರಗಡೆ ಬಂದಾಗ ಅವರನ್ನ ನಾವು PHC ಕೂರಿಸಿ ಅಥವಾ ಜನರಲ್ ಪ್ರಾಕ್ಟೀಸ್ ಕೂರಿಸಿ, they are not ready for the market. ಮಾತೆತ್ತಿದ್ರೆ CT ಸ್ಕ್ಯಾನ್ MRI ಅಂತ ಹೇಳ್ತಾರೆ ವಿನಃ patient na sitting with the patient, talking to the patient, or doing simple skills they don't have. That means we have lost in touch with reality. So that is the reason now what Dr. Manjunath has said is primary care psychiatry dela, which the same program when it was discussed with AIMS Rishikesh, the director of AIMS Rishikesh said, sir, this is the time we require primary care obstetrics, primary care maybe surgery, because we have to answer the public's problem, and we have to now retrain our MBBS doctors to deal with the problems what they can see in the PHC or district hospital, not in the medical college, which have various investigations. There are very good specialists, and they think that yes, I have to work in a medical college, but we have not prepared our doctors for PHC. That is the unfortunate thing.
No, we need not only primary care psychiatry, we need primary care pediatrics, we need primary care obstetrics, primary care gynecology, all kind of specialty. There should be primary care version also, which should be the ideally it should be taught to MBBS doctor during MBBS course itself. In that case, the DPCP course is the question of DPCP course doesn't arise if they are properly trained during MBBS.
Yeah, you can move further.
Yes, sir.
Any questions from audience?
If no question, I also recognize the presence of Dr. Suresh Kurwa, the incoming president, and also I also thank Dr. Karant, the chairman of the psychiatry cell, for giving an opportunity. Now I'll hand over the stage to Dr. Madhusudan to conclude the session.
Yeah, thank you very much. On behalf of IMA Karnataka State Branch, I thank the resource persons for this webinar, Dr. Manjunath, well supported by Dr. Suresh Badamat and Dr. Deepak Aris, and chaired by Dr. Harish Talantapettu. I also thank Dr. Venkatesalpati, our president, and also our state secretary, Dr. Prasad Asam, and also our IMA Karnataka State Branch Psychiatry Cell Chairman, Dr. K.S. Karant, and also our President-elect, Dr. Suresh Kurwa, and President-elect Dr. Shubham Kumar, and all other members. And also I congratulate my classmate and my friend Somsekhar Bijal, who is also Secretary of IPSKC, for taking these webinar series in a very well staged manner. And I thank all the participants on the YouTube and Zoom platform. And this thing is available. It is forever. It is available, and it is in the IMA Karnataka State Branch YouTube channel. Anybody can on their leisure time they can listen to this lecture. Yeah, thank you very much. Over to Somsekhar.
Actually, there was some feedbacks that these initial 2 sessions, what we did were more about demographic details about the prevalence of the psychiatric disorders and what things are actually going on at the research level. And over a period of time, we're planning to, they want more. I feel there are some feedbacks that how to elicit the signs of depression, how to elicit the signs of anxiety, all those things.
No,
In the
till now
coming
it
session,
was a trial.
yeah. In the coming sessions, those things will be there. And this
film baki hai next session.
Yeah. It's a more of trailer now. Abhi picture abhi baki hai, sir. Thank you one and all, sir.
Just to create curiosity, we are doing this, and next onwards will be a real crux of psychiatry will come.
Yes.
Thank you very much. Good night.
Thank you.
Thank you, sir. Thank you.
Thank you, everyone. Thank you, everyone.
We'll end the show.